Good morning, everyone, and welcome to today's community conversation, Eating Disorder, Signs, Symptoms, and Resources. Thank you for joining us, whether you're watching here on Zoom or if you're joining the live stream on the NASW New Jersey Facebook page. We'll be getting started in just a moment. I just want to give another minute or two for everybody to get connected to the call, and then we'll begin. For those of you watching on Facebook, if you have questions for the presenter, you can put them in the chat on Facebook, and we will transfer those over to the Zoom call. Otherwise, enjoy the presentation, and we'll get started shortly. Okay, it looks like everyone who is in the waiting room is connected now. So in the interest of time, we will get started. My name is Jeff Feldman. I'm the Director of Advocacy and Communications here at NASW New Jersey, and I will be moderating today's community conversation. And as said, you are joining the presentation Eating Disorders, Signs, Symptoms, and Resources. And we're very happy to have with us here today Nancy Graham and Ashley Moser from the Renfrew Center. Before I turn things over to them for the presentation, just a couple of housekeeping items. Please be sure to keep yourself on mute if you're not speaking. Just a reminder, we are recording this presentation for future use. So we just want to make sure that there's no background noise or any inappropriate conversations that shouldn't be overheard being had in the background. You will have a chance to unmute and ask questions during a Q&A session after the presentation. You can also put your questions right in the chat, and we'll either hold them for the Q&A session, or if it's something that we need to address in the moment, I'll interrupt the presenter to ask that question. So with that said, I think we are ready to begin, and I'm really happy to turn things over to Nancy. Thanks for being here with us today.
Well, thank you so much, Jeff. We're so happy to be here. Always happy to collaborate with the NASW, especially New Jersey, because I've been a New Jersey resident for my whole professional life. So, and been involved with the NASW. Yes, I am Nancy Graham. I am an LCSW. I am the professional relations representative for the Renfrew Center located in Paramus, New Jersey. I'm just going to give you a little quick history about Renfrew for those who are not familiar. I won't take too much time, but Renfrew was actually the first residential treatment facility that was ever set up in this country in 1985 to treat eating disorders. We have continued to provide expert treatment for anorexia, bulimia, binge eating, as well as a full range of other eating disorders. As long as the primary diagnosis is an eating disorder, we can treat you at Renfrew. We, at this time, treat everyone except cisgender males. So we have expanded our treatment base. We do accept over 400 insurance plans, and we do have 19 locations throughout the country. We are in many different states. Our 2 residential facilities are in Philadelphia, which is our original location, as well as Coconut Creek, Florida. We have treated actually way over 85,000 patients. We are quickly approaching our 100,000 patients. So we will actually be celebrating that hopefully later this year. And again, we continue to be actually what's interesting about is we are a family-run business, which is very unique to eating disorder treatment facilities now. And we are family-owned and run. So that is, again, very unique. Our 2 locations in New Jersey are Paramus, where I'm located. We used to actually be in Ridgewood. So those of you who may have thought of Renfrew being in Ridgewood, you're correct. We did move right at the beginning of the pandemic. We've been there for a couple of years now, and we are back to full in-person programming for day treatment and IOP. We also have a location in southern New Jersey in Mount Laurel. And we have also a White Plains location, not in New Jersey, but very close, as well as we have one in New York City. And at all of those non-residential sites, we do have day treatment, which is 5 days a week, as well as IOP programs. Usually the IOP is in the evening, but we also do day IOP. We also have another new exciting program called Renfrew at Home, which is a totally 100% virtual program. We did provide totally virtual programming for our non-res programs during the pandemic. As I said, we've gone back to in-person, but we also realized that there were many, many patients that didn't live close enough to any of our sites, including some patients in New Jersey who might be right in the middle of the state, who might not be able to get to either Mount Laurel or Paramus. So we realized that we really wanted to continue to provide services for these patients. Access of care is so important, especially with the increasing number of eating disorders. So we do have something called Renfrew at Home. It's the same exact program, but it's separate from our in-person programming. But we do provide the same day treatment and IOP program. So I'm not going to continue to talk for too long. I know we have limited time today, but please feel free to reach out to me at any time. My contact information, I believe I'll put it in the chat for everyone, but I believe it's at the end. But I'm happy to help in any way I can. If you ever want to make a referral, you have questions about a referral. I hope to see all of you who are tuned in maybe at the NASW conference coming up in May. I will be there at the Renfrew table, so I'd love to say hi to all of you. Also, just quickly, we do in-services. So if you are looking for any kind of an in-service for your staff, I am an LCSW, do a lot of that type of thing. So feel free to reach out. Anything you have questions about, I'm happy to answer. So with that, I will turn this over to Ashley, who will do our presentation today, who is our clinical education specialist. And Ashley, you're on now.
All right. Thanks so much, Nancy. And,
Okay.
and thank you so much for everyone to take the time out of their busy days and lives to spend a little time learning more about eating disorders. So there is so much to say and learn about eating disorders. So I've had to sort of prioritize some of the main important messages that I want to really have everyone take home today because of the limited time. I am someone who historically packs a lot of information into my presentations, and I can speak rather quickly because of my desire to get so much in such a short period of time. So if you have questions, you want more information, we'll have time for Q&A today, as well as, like Nancy mentioned, lots of opportunities for us to talk in depth on any of these topics. I'm really excited because today in particular is the start of our Eating Disorder Awareness Week, and it is a time where we really try to push forward information about eating disorders so that we can increase awareness, informed care, and access. So thank you so much for taking time to participate in that week by learning more about eating disorders so that hopefully we can reduce stigma and increase, of course, that resources. So I think the most important piece to start out with is that there are a lot of misinformation and myths and stereotypes connected to eating disorders, what they are, who they affect, and what they look like, for instance. So I think the first slide that I like to start with is to at least acknowledge that eating disorders, as much as they are about food, they are not just about food and weight. So it's important that we as providers, community members, parents, children, expand our minds beyond just what we think eating disorders are and be open to the fact that eating disorders are not just about food and weight, but are actually about emotions. We consider eating disorders emotional disorders, and they can be very secret and insidious, which makes our awareness and our kind of dedication to learning more about these illnesses so important, because they aren't something that are recognized easily in today's society. They are so much more about food and weight again. They tend to be much more about being a way to deal with conflicts and pressure of daily life. They're a way of managing intolerable feelings and exerting control. So as much as the relationship about food and weight is something we will be talking about throughout this presentation, it's important to remember that eating disorders are not just about food and weight and have far more to do with emotions and the way that we manage emotions than they are about the food and weight numbers. Eating disorders can be very difficult to identify in today's society, and here are a few of those reasons why. They're not always readily seen, And this can really be contributed to our societal views of what is considered normative or accepted practices around dieting and exercise in today's culture. There's a lot of pressure to be a certain size, to be engaging in behaviors that actually are considered disordered or eating disorder behaviors as a part of what's considered just normal weight maintenance. I want to encourage all of you to sort of throw away those ideas, or at least be a little skeptical about some of those ideas, because a lot of how eating disorders remain very unseen and secretive is because we believe that some of the behaviors that are actually disordered are actually something that are normative, that what most people should be engaging in. So we need to push back against some of those ideals, and we'll talk more about that later. Oftentimes those with eating disorders actually do function quite well in a lot of areas of their lives. So this isn't someone that you're seeing is also struggling in school, is struggling at work, is struggling at home, is struggling to keep up. This may be someone who's actually performing very well in kind of our standards when it comes to performance in day-to-day life. And the eating disorder actually helps them continue to do that. So when we pull away the eating disorder, when we work on that piece, sometimes the functioning for that person actually does change. But one of the reasons why they're so hard to identify and see is that this isn't someone who may be stereotypically struggling the way we would expect them to be, as if they were struggling with any other mental health condition. There's also a lot of denial, secrecy, lying, and shame that accompanies eating disorders, which again makes them very difficult to identify. The person who themselves is struggling may not acknowledge that they are struggling, may not think that there is a problem or that they have a problem, or that if they do have a problem, they work very, very hard to keep that secretive from the people around them. Another reason why eating disorders can be challenging to identify is that they typically do not travel alone. So oftentimes, those who struggle with an eating disorder often also struggle with other co-occurring mental health concerns. So this is somebody who's struggling with anxiety, depression, PTSD, or trauma symptoms, OCD, substance use. Most of those people with an eating disorder diagnosis also have a mental health diagnosis in conjunction with that. So because of that, it can be very difficult to know that an eating disorder might be present, because the person who's presenting for help or support may be asking for help or support with depression or anxiety, and not necessarily show up and say, I need help for the eating disorder. And sometimes we feel like, well, is the eating really that big of a deal? Or is it more about the anxiety, more about the depression? And if we resolve those things, the eating will get better. So I think that's another important piece to remember, that it can be hard to identify an eating disorder because it tends to come in conjunction with other mental health concerns as well. Another piece that makes eating disorders difficult to identify is that disordered eating really does come on a continuum. Of course, we have the DSM diagnosis that you can check those boxes and say this person meets criteria for an eating disorder. But there are a lot of subclinical and prevalent ways of engaging with food and exercise and feeling about body that do meet criteria for support with disordered eating. So I think it's important to remember that it's not just as simple as saying this person struggles and this person doesn't because they check 3 boxes versus 4 boxes, that our relationship with food and body and movement is really on a continuum. So I think it's important to acknowledge that eating disorders themselves are hard to identify because the relationship with food and body and movement is so complex and can occur. And those who need help may struggle even if they don't necessarily meet criteria for a diagnosable eating disorder. So next, again, because of interest of time, I'm going to kind of go into some of the categories of eating disorders that are present currently in today's, DSM. But I'm also then going to talk a little bit about some of the other kind of rising or more prevalent eating disorder behaviors that we're starting to see come to the surface in our treatment, just to make us, again, fully aware so that we can identify eating disorders when we see them. So the most recognizable and probably most commonly associated with eating disorder presentation is anorexia or nervosa. So this is someone who typically is engaging in some level of self-imposed starvation. So this is when the body is hungry, choosing not to eat. This involves a lot of denial and restriction. And some of the behavioral warning signs include perfectionism, obsessive thinking, anxiety, low self-esteem. There can be disordered body image. There's a preoccupation with food, calories, nutrition, and exercise. There can be a lot of compensatory and compulsive self-weighing. And there can be, a desire to hide when the body is shrinking by wearing larger clothing. So this is probably the most stereotypical vision of what people think of when they think of an eating disorder. Those with anorexia may, but not always, be in a lower weight, and they may then be restricting and denying themselves the food that they need to nourish their bodies. This is one classification. This is one component of eating disorders, but there's many, many other presentations. One of the things that makes eating disorders, again, so important to be working through is that eating disorders, while difficult to identify, also have a lot of serious physical and medical complications, which makes them unique in terms of mental health illnesses. So in terms of anorexia nervosa, some of the physical signs and symptoms are what you see on your screen today. So this may be someone who not only is struggling with food intake, but is also experiencing medical complications that can result in them then having serious medical complications long-term. They may be diagnosed with larger medical complications and even can result in death in some extreme circumstances. So it's important for us to be paying attention, not just to the behavioral warning signs of what we see for anorexia, but also some of the possible medical complications. Catching these as a sign or a symptom may be the difference between someone being medically stable or medically having complications that could be very serious and life-threatening. So we can see this really anorexia impacts the entire body system. We're talking all the way from hair, all the way down to the GI tract and everything in between. An important consideration when it comes to anorexia nervosa is weight. And we'll talk a little bit more about weight stigma, bias, and discrimination a little bit later. But I do think it's important that even though the stereotypical vision of what we see or think of when we think of eating disorders is someone in a smaller body, someone who's emaciated, someone who's malnourished. The majority of people who struggle with anorexia are not malnourished, or are malnourished, but are not in a lower weight body. So what the term is typically used right now to be able to identify these individuals is someone who's in a body that is not considered below weight is atypical anorexia nervosa. So they're still experiencing all of the symptoms of anorexia nervosa, but their bodies are not considered underweight, but are still considered malnourished. So again, important for us to expand our minds and visions about who struggles with an eating disorder, because it is possible to struggle with anorexia nervosa, have all the signs and symptoms, as well as have all of the possible medical complications, even in a body that's not considered underweight. Bulimia is another kind of well-known or a diagnosis that maybe more people are aware of or think of when they think of eating disorders. This is someone who struggles with a repeated cycle of out-of-control eating, followed by some form of purging. So this can be done through self-induced vomiting, laxative use, diuretics. There can be water loading as well. Purging can also include exercise. So it's important to acknowledge that someone could be struggling with bulimia, even if they're not using self-induced vomiting to as their compensatory behavior to manage what they believe is the resulting weight gain that can come from binge eating. So this may be someone from a behavioral warning sign perspective that engages in binge eating, can't voluntarily stop, may react to emotional stress. They may be considered more impulsive. There can be moodiness or a depression, feeling of out of control, but then the biggest component is that purging, that compensatory behavior, which again can be through self-induced vomiting, as well as a lot of other possible behaviors. And here are some of those other possible behaviors. I list these because I do think it's important that we, again, expand our definitions of who struggles with an eating disorder and how they struggle. So we see that vomiting is high on the list, that 90% of patients do use that behavior, but there's a plethora of other behaviors that also then mean that that person could be struggling with bulimia. And again, because eating disorders have the medical component as part of the diagnosis and as part of what makes them so important and so medically complicated, we also want to be looking out for some medical symptoms as well. So this is someone who could be experiencing, again, anything from head to toe, that there could be a medical complication and a serious medical complication that can result in life-threatening and even death as a consequence. So this is because the eating disorder behaviors can absolutely impact the cardiac system as well as the GI system. We also see a swellingness that can happen in the jawline and cheek for someone who is engaging in self-induced vomiting, but there is a plethora, again, of medical signs and symptoms that could be occurring in someone with bulimia that we also have to be keeping an eye out for, because noticing these, again, could be the difference between someone continuing on with behaviors that are life-threatening or being able to get support and help. And just a quick note on exercise. We know that exercise can play a large component when it comes to eating disorder signs and symptoms. There is such a thing as too much exercise, even though today's society may encourage exercise in all shapes and forms, but there is the possibility that exercise can be unhelpful and even harmful. So this could happen if someone is training or exercising despite injury. They're maybe doing more exercise than what is needed for punishment, especially in response to it, trying to balance out what they've eaten for the day. They don't give themselves rest days. They have to engage in the movement, and that the exercise really takes precedent over relationships. I've had clients and their family members say that they're not, a member of our family anymore. They're not married to me. They're married to exercise now. And I think that was sort of an indicator that the exercise was taking precedent over the marital relationship in that situation. Binge eating disorder is another diagnosable eating disorder that we often see. This is typically defined as someone who compulsively overeats or feels out of control when they're eating. How do you know if it's binge eating versus just eating more than is usual? Typically, the biggest sign is that they're eating a large amount of food when not physically hungry, that the eating itself is more rapid than usual. It's eating to the point of being uncomfortably full and feeling almost out of control or dissociated when engaging in that eating. The biggest difference between this and bulimia is that there is no compensatory behavior. So the binge eating does not result in any sort of compensatory behavior. However, the binge cycle does have a level of compensatory behavior to it. So what we typically see is most people are presenting for help with binge eating. They're focused on the binging portion. They're not necessarily aware of the fact that there's also some restriction that's happening as well. So the majority of the time we're seeing people who are struggling with binge eating, they're feeling out of control, eating larger portions and quantities than they want to, and then they're not eating to try to compensate for the fact that they ate more than they wanted to the day before. But by not eating, you are then setting yourself up to engage in binge eating because of the restriction that's taking place. So we often see people who are presenting for the binge eating behavior. However, restriction is a very important component to this as well. So it's important to pay attention not just to the overeating, but also the compensatory restriction that may be happening, which is continuing the binge cycle. And here again, some of those medical complications, which can be the difference between someone struggling with a life-threatening illness and someone who's getting support. It's important to pay attention that there are medical complications with eating disorders and all eating disorders. So here are a list of those again from head to toe that can be impacted. And I think some of the pieces to really focus in on, we have polycystic ovarian syndrome. I think we see a lot of people with binge eating that also have that diagnosis as well. But there can be a lot of additional medical components that can also be a complication of binge eating disorder. And again, because we'll continue to talk about weight, people who engage in binge eating are not always in a larger body. People who are in a larger body do not always binge eat. So these medical complications may or may not be connected to the actual weight of the individual, and it's important to learn to separate the two. So now we're going to talk a little bit about some of the kind of subclinical or more specialized diagnosis that we have. Those were sort of the top three that I think people think of when they think of eating disorders. And we're going to talk about some of the more intricate diagnoses as well. So there can also be something called diabulimia. So this is an eating disorder that presents in those who have type 1 diabetes. And it's the intentional insulin abuse in order to lose weight. Obviously, we're hearing more and more in the media about the role of insulin and the insulin drugs in weight loss and how that's being prescribed as a mainstream way of losing weight. So that is actually the engagement in some diabulimic behaviors, which is something that is very dangerous. As you can imagine, type 1 diabetes with the connection to a disordered eating can also create life-threatening consequences. So definitely want to push back against that current trend that seems to be popping up everywhere, and be thoughtful of the fact that those that you do know in your life that do have type 1 diabetes, that checking in with them about their relationship with food and their body and insulin. Orthorexia is another term that is becoming more and more mainstream and more focused on. And orthorexia is really the obsession with eating correctly. consuming healthy food and avoidance of unhealthy food. So there's a lot of conversation about, I was good, I was bad, I only eat healthy, I'm eating clean, I eat unprocessed. This belief is that I eat these foods because it gives me a sense of good morality. I feel good about myself if I'm eating good foods. But what ends up happening is that it becomes obsessive. It becomes pathological to the point of social isolation and extreme weight loss. So what we see is that people are only eating certain foods, and that window of food that they allow themselves gets smaller and smaller and smaller until they're only able to eat a certain number of foods and actually experience malnutrition as a result. So it's important when you hear people speaking a lot about their good foods and bad foods, their healthy foods, their unhealthy foods, that you're paying attention to how that then is impacting their overall well-being and functioning. Are they experiencing medical complications as a result? Are they alone more than they would like to be because they can't eat out with other people because of the desire to eat clean? These are the kinds of things we want to keep an eye out for. And yes, a little bit more information on orthorexia, that it tends to not be as much of a weight focus or a desire to lose weight. It tends to be far more about that being healthy, being natural, being morally right, than it has to do with about changing the body. The body does change as a result, though, of pursuing those other goals. Here are a few additional eating disorder diagnoses. So we have other specified feeding or eating disorders. We have ARFID, which is a diagnosis that we are treating more and more. This is similar to orthorexia to some degree, but tends to be that the restriction or the avoidance of foods is not based on the morality. It's based far more on textures. So if we have those who are on the autism spectrum or struggling with sensory processing disorders, we do see this showing up in those populations more frequently. But this is something in which the textures or the types of foods that this person allows themselves to eat become so small that they are then only able to eat certain foods, and those certain foods do not necessarily result in them being as nourished as they need to be. So malnutrition, medical complications, all can arise from this as well. It can also be a part of those who have a fear of vomiting, as well as a fear of choking. We do have a lot of people presenting for treatment to address those fears, because the window of foods that they allow themselves to eat that they're not worried about vomiting or choking on becomes so small that they do experience medical complications once again, if not social and relationship consequences as well. There are a few others in here, but I think those are the two I want to hit on right now. So I think we've done a very quick job of going over some of the basic eating disorder diagnoses, but the biggest message I want you all to take home today is that eating disorders do not discriminate. They impact anyone and everyone, and we need to be screening, assessing, and paying attention to eating disorders and the possibility of an eating disorder in anyone, and throwing out some of these stereotypes and myths and misconceptions that we have about who is impacted. So eating disorders can impact anyone and everyone based on age, race, gender, ethnicity, SES, sexual orientation, size, and ability. That there is no characteristic that puts you on the list of you are not impacted by eating disorder, or the possibility of an eating disorder is not possible for you based on a certain demographic or criteria. Anyone can be impacted, and it's important that we start addressing and treating and looking at eating disorders through this lens. So when we think about the LGBTQIA+ community, it is very well known that this population, because of the intersection of some of the identities, that there is a greater risk of development of eating disorders. Because like I said at the beginning of today's presentation, eating disorders are emotional disorders. Any population that is at a higher risk of an emotional disorder based on systemic racism, discrimination, oppression, marginalization is at a higher risk for a mental health condition, and therefore is at a higher risk of an eating disorder as well. Here are some of the reasons that are specific to this community as to why there is a higher risk factor. So there's the fear of rejection or experience of rejection. There's internalized negative messages and beliefs about yourself. There's discrimination or violence. There's bullying. Of course, the disconnect that can sometimes happen between one's biological sex and gender identity, and inability to meet body image ideals within this community. So research shows that beginning as early as age 12, that these teens may be engaging in eating disorder behaviors at a higher rate than their heterosexual peers. So we want to be looking at this population in particular. We know that eating disorders can impact anyone, but if someone is coming to you and is a part of this community, we want to be especially attentive to the possibility of an eating disorder being a part of their presentation or something that they could be struggling with. Same for those in the BIPOC community. So research has really shown that systems of power contribute to eating disorders and affect minority ethnic backgrounds dealing with disordered eating differently than their white counterparts. So we have learned, through, the experience of, trying to expand the field, trying to make access to care, research, all of this more inclusive, that there is a big gap between who struggles with an eating disorder, who is getting treated, who is being researched, what the data is providing. There's a huge gap. And so unfortunately, BIPOC population is less likely to be diagnosed. There's a lot of studies out there right now that are showing that, when someone in with a BIPOC in the BIPOC community presents with an eating disorder in comparison to someone in another community, that they are less likely to be treated, diagnosed. And that's a big concern because there's a huge gap in the care that's being provided. So we know that BIPOC patients are less likely to be diagnosed, to receive treatment, and are not necessarily represented in who is providing the treatment. So we know that people of color with self-acknowledged eating disorder with self-acknowledged eating and weight concerns were less likely than their white counterparts to be asked by a doctor about their eating disorder symptoms. So because of all of this, we know that there's limited research to date, but here's a few of the research statistics I was able to find. So we know that Black teenagers are 50% more likely than white teenagers to exhibit the behaviors of binging and purging. We know that research found, I won't read all of this to you. You guys can read it on your own just due to the nature of time, but we see that there are some actual differences in how BIPOC patients present in different eating disorder symptoms than others. But again, there's a lot of research that is left to be done, a lot of access to care and information to be gathered so that we are providing informed care. When it comes to weight stigma and bias, it's important to be thinking about this as an element that can also be a piece that keeps people from being diagnosed, treated, and getting the care that they need. We know that, again, that stereotype that someone in a smaller, underweight, malnourished body is someone who struggles with an eating disorder, but only 6% of those who struggle with an eating disorder actually fit that criteria. 6. The majority of people are in normal to higher weight bodies. And it's important that we're looking at, again, everyone and anyone for struggling with an eating disorder. So weight stigma and bias is something that we're hearing more about, but still has a long way to go. We know that weight stigma or bias is actually considered discrimination, and discrimination is based on weight. So weight stigma can increase someone's body dissatisfaction, which is a big risk factor and leads to the development of an eating disorder. So I thought it was interesting that the best known environmental contributor to the developmental of eating disorders is the sociocultural idealization of thinness. So if we think about what is the biggest factor, at least environmentally, when it comes to the development of an eating disorder, is this buying into weight stigma, weight bias, and experiencing weight discrimination. That's a big, big component. We also know that when it comes to eating disorders, 60%, I think, is the percentage that I've seen most recent, shows that 60% of the contributing factors are genetic. So coupled with the genetic component, in addition to this environmental contributor, that tends to be creating a lot of risk for eating disorders. And also to do a quick kind of overview on eating disorders in adolescents, we've been taking a look in particular about how the impact of the COVID-19 pandemic has impacted our adolescents, because I'm sure, as all of you are aware, the pandemic has created a mental health crisis, period. And then, of course, a mental health crisis specifically for adolescents. So we know that those following the pandemic and adolescents are reporting higher rates of mental health concerns. And we know that youth that struggle with mental health are more likely to struggle in school with their decision making. They have worsening physical health, and they do have a higher risk of drug use, high-risk sexual behaviors, and eating disorders. I think it's also important to sort of note that in the wake of the COVID-19 pandemic, the adolescent mental health crisis, we are seeing an increased risk of suicide in today's youth. So it is a leading cause of death among youth. We also know that suicide is a leading cause of death in those who struggle with eating disorders. So medical complications increase the likelihood that someone could die via the eating disorder. Suicide is another component. So we want to be paying attention, especially to our youth, our adolescents who are struggling with disordered eating, because they are at a higher risk of engaging in attempted and completed suicide. So interestingly enough, in February and March of 2021, visits to the emergency room for suspected suicide attempts were 50% higher among girls ages 12 to 17 than in 2019. So a 50% increase in this specific demographic and population. And I believe there's been more studies that have come out more recently that have really seen, in particular, a mental health crisis for adolescent girls. So I think we're going to continue to learn more and more about how the pandemic and the years prior or the years following have impacted their mental health, but we're definitely seeing an increase in mental health struggles in very, very scary and significant ways. So I think we've laid a decent foundation today of signs and symptoms, as well as, some of the, specifics that we need to be paying attention to in certain populations. Now what do we do with this information? This is where I think we need to kind of, end our conversation. So how do we help? I think the first thing that we do is attend informational sessions like we have today, where we're learning more about eating disorders so that we can push back against some of the stereotypes that really limit who is being seen, receiving support, and who has access to help. If we do know someone in our life that is struggling with disordered eating, what do we do? I think that's the biggest question we get sometimes in the work that we do is, how do I help someone? I know it's a problem. They know it's a problem. What do I do with this? So approaching someone who exhibits symptoms of an eating disorder can be really delicate. I think there's a lot of fears, like if I say something, am I going to make it worse? If I say something and they don't, want to get help, then what do I do? There's a lot of fears that come up for someone who suspects an eating disorder, but is not sure what to do next. I want to encourage anyone who is concerned about someone in their lives, professionally or personally, to have the hard conversation. It's so important that even though it's scary, even though it's hard, eating disorders are one of the deadliest psychiatric disorders. It's actually number 2 at following opioid abuse. And so because of this, we really need to make sure that even though we feel scared, worried, concerned about having these hard conversations, we need to take that step, because we could, again, be, impacting and saving somebody's life. So even though it's difficult, I encourage you to bring these conversations to those you're concerned about. Here are some of the ways to think about having that tough talk. Getting education on eating disorders. You don't want to broach the topic if you don't really know anything about it. So you want to get some education. There's some great online resources, which I will list at the end so that you can have some places to go to get some additional training and support. When you do express your concerns, you want to use I statements. You want it to come from a place of, I care about you. I see you. When I see this, I'm wondering, versus you're doing this, you're doing that. We also want to make sure that you stay away from talking about weight and size as an indicator of whether this person is okay or not. As we've seen, as much as weight has been it is a component of eating disorders, it is not actually a huge signifier as whether someone is healthy or unhealthy, struggling or not struggling. So we want to take that off the table, and we want to focus on the things that you've noticed, that they're more withdrawn, that they're not themselves, that you miss them, that you miss spending time with them, and that you've noticed that things have changed. Those are the places that we can elicit and start these conversations. We also want to stress the importance of professional help. Because eating disorders are so deadly, because eating disorders are so complex, we want to make sure that we're supporting people in getting to professional help, informed care, care that's going to be able to see them and address the eating disorder from an informed perspective. So as much as we as family members, as friends, as coworkers want to be able to be the person that can help the person we love, sometimes it's outside of our scope. And I would say with eating disorders, most of the time that is the case. So getting someone the support that they need and getting them to a professional is very important. You want to also identify who are the supports in this person's life. What's their family relationships like? What's their friendship circle like? Do they have supportive coworkers, community, church, whatever that is? What are some of these other supportive communities and support systems that can help this person reconnect to their values, reconnect to what they care about? And one of the statements that I make at the end of every time I talk about this is that you need to be patient, yet persistent. This may not be a one and done conversation. Pulling someone to the side, expressing your concern, and encouraging professional help may not be a one and done, but you need to be patient and supportive. Show that you're there for that person, but continue to offer that professional support, continue to offer the guidance to get them where they need to go. So just to be open to the fact that it may not be a one and done, it may be a continued conversation, but getting it started is the hardest part. But hopefully these are some steps that can help you feel like you have a place to go with that. If you are a professional, Renfrew has some fantastic resources that we offer. Some are free, some are paid, but we do have a lot of opportunities to be able to be trained from a very intensive level all the way down to just a basics informational level. So we have an annual conference, we have free webinars, we have free CE events. There are consultation groups that exist. We have a treatment manual that is easily as bought on Amazon. And we also offer support groups for outpatient from the outpatient level through a lot of other, specialties. So I encourage, resources professionals when it comes to Renfrew. We have a ton of those, and Nancy will be your go-to for being able to link you with any of those in the future if those are of interest. And then when it comes to resources for everyone, I just want to plug some really great national resources that have free support groups. They have free webinars, they have free trainings. They are a wealth of information. I pulled some of our statistics today from today's training from these websites, but these are just a few of many resources that exist that offer free support groups, not just for those who are struggling with an eating disorder, but even those who are loved ones of someone struggling with an eating disorder, trying to learn how to support and do the best they can to move that person towards recovery. And I've got my information at the end, but I know Nancy's going to enter hers into our chat as well. I think she already did, but this is my contact information. If you ever have any questions, any needs, any support, I can happily get you in the right direction. I know this was a fast and furious presentation today when it comes to the basics of eating disorders. And I am more than happy to answer any questions or just be able to speak to anything that's come to mind in our conversation this afternoon. So thanks for your attention, and let's see what questions we have.
Thanks so much, Ashley, for that wonderful presentation. Really a lot of good information in there. And I love that you were able to highlight some of the newer diagnoses or sub-diagnoses that are out there now, so people can see the full range of what's falling into to eating disorders. So if you have questions for Ashley or for Nancy, feel free to raise your Zoom hand, or you could type your question in the chat if you don't like to come online and speak. So any questions for our presenters? I see something just came in the chat. Let's see here. Sarah says, I work with a lot of adolescents who don't identify with having an eating disorder, but report they don't feel hungry and are significantly underweight. Any recommendations for increasing hunger cue awareness or assessing them?
Yeah, that's tough. And depending on the level of malnutrition, they may not actually have hunger cues, which can be really challenging because, of course, we want people to be going towards their intuition. We want them to be eating intuitively and like getting those signals internally. Depending on how malnourished someone is, they may not actually have those hunger cues, or they may be so disconnected from them that they can't trust them. So I would say if you have an adolescent who is demonstrating signs and symptoms to you of disordered eating, even if that awareness isn't there, I would look to see if there's the possibility of connection at minimum with a registered dietitian. I do think dietitians have a way of being able to incorporate meal plans and change nutritional intake without necessarily having to have it labeled as an eating disorder. Sometimes that label itself can push people back from wanting to get support or looking at that differently. But I do think that through, working with a registered dietitian, that can be a really helpful next step in at least figuring out, if you don't have those hunger cues that we can anchor into, what are your nutritional needs? Let's figure out what those are. What do you need to be intaking each day? How often does that look like? And let's put a plan in place. And I think a dietitian would be a great place to be able to do that, because if we don't have the intuition to be able to anchor into to make our meal choices, sometimes it's really helpful to have a plan, and dietitians do a phenomenal job with that. I think getting families on board with that, of course, would be really, really important too, because as adolescents, families are the ones who are actually executing those meal plans, are executing those next steps in a lot of cases. So I do think bringing family in, talking about that as a recommendation and working with the family to support that too can be really helpful. But I just echo and empathize with the concerns around the denial or just the lack of insight and awareness of the eating disorder, because that can be a big step and a big hurdle in itself.
I can just add about the denial, Ashley, because one of the things that I know I hear a lot is, that eating disorder patients are in such denial, they're so resistant. And I always like to say that this is not this is not an intentional denial or resistance. We have to really remember, and what you said in the beginning, that really the eating disorder is a way to cope with dysregulated emotions. So in a way, if you look at it, it's kind of a highly adaptive coping mechanism that's not done consciously, and it's working to some extent for the patients, which is why it's so hard to give up. We're asking them to give up something that for them feels like it's working and it's serving a purpose. And so oftentimes that's why we do need to use family members or others to really get them into treatment, because they're not going to be so willing to say, yes, I want to give this up. It's hard work. And so it's not really a purposeful denial or, I like to, again, I just like, because people, they say like, they're so resistant and they're such denial. Why can't I convince them? If you ask anyone to give up a coping mechanism that's working for them, they're going to be resistant, and no one really wants to do that because we need them in life. Unfortunately, the eating disorder becomes another whole problem at that point. So kind of just understanding that, I think when you're approaching someone, is really helpful.
I think that's great.
Yeah, thank you both for addressing Sarah's question. Our niece in the chat is asking, do you find African-American males presenting for assessment and treatment?
Yes. Since eating disorders, affect everyone and anyone, yes, that is the case. I do think that because there are so many demographic identity, and identities that may go against the normal stereotypical eating disorder patient, there are barriers. So I will say that those particular populations are presenting for treatment, but I would say in smaller numbers. And I do think that's because of a lot of those existing stereotype stigmas that really do prevent those individuals from feeling like they can access care, but also even identifying those needs within themselves sometimes, because I do believe there's a lot of misinformation out there about who's impacted by eating disorders. And so therefore there's difficulty identifying, is this something I could be struggling with? In addition to, is this something I could even access help for? So I think there's a lot of steps that happen even before those people present for treatment. But I just, I think there's a lot of the discrimination, racism, a lot of the those pieces that I think still very much impact care.
Also, just to quickly point out, sorry to keep in here, but it's not necessarily the stereotypes, absolutely true, but even just not understanding eating disorders. The DSM really only changed the diagnostic criteria for anorexia in the most recent DSM. Prior to that, in order to be diagnosed with anorexia, you had to have a loss of menses. So it was not ever even considered in the community that treated eating disorders that a male could have anorexia. We know that's not true now, the more we've learned about it. But, it's a quickly, evolving science about really not knowing much. Thinking about the fact that Renfrew was the first eating disorder treatment center, and that was only in 1985. So anyway, it's, there's just a lot that we're learning, and it's fortunately changing quickly. But, even the diagnosis was not correct at that point. So just wanted to throw that in.
Thank you both again. Aaliyah is asking in the chat, how does body dysmorphia inform work with eating disorders?
Yeah, I think that's a huge piece. I do think body dysmorphia presents not in everyone with an eating disorder. I think there's negative body image and then there's body dysmorphia. So I do think that those who struggle with body dysmorphia, I think that body image acceptance and tolerance can be so much more challenging and so much more intensive when it comes to the recovery process. So I do think that those who are actively engaged in eating disorder symptoms are able to, work through normalized eating patterns and sort of recovery from the eating disorder symptoms. But the relationship with the body is something that's going to take far longer to work on. It's going to take much more work and can be more challenging to sort of do. So I think that tends to be, when we're talking about higher levels of care, we're maybe laying the foundation for some of that work. But when it comes to body image dysmorphia, I think that's something that can definitely be work that has to be done, not just in higher levels of care, just the foundation's really laid there. And that continues to be outpatient work, because it's very hard to connect to, eat intuitively with, and adequately assess how nutrition and how is impacting your body, how you feel about your body, when your ability to connect to it is so impaired.
Also, I think as a follow-up to what you were discussing before, Aaliyah had another question. We talked about replacing existing coping mechanisms. And are you able to share maybe just a couple of examples of what type of coping mechanisms are used to replace the eating disorder behavior?
Yeah. So our ultimate goal ultimately is to step away from getting into that perspective of having to have a coping mechanism. So there is the ability to replace eating disorder behaviors with distraction, the ability to replace it with something else. But what we really want to lean towards, and what the model that we use at Renfrew is designed to address, is emotion tolerance and emotion regulation. Because what we find is that the eating disorder symptoms and behaviors tend to serve that function of being an external way to, regulate an internal state. What we want to work towards is for each individual to be able to regulate their internal state without having to rely on anything external. That takes a lot of work, as you can imagine, because if you've spent, a good chunk of time using and relying on a skill or a symptom or a behavior to cope with difficult life circumstances, taking that away and not replacing it with something else feels like a big drastic change. But that's where, having, educated professionals to be able to support you through that process is so important, because working on that ultimate emotion regulation and tolerance is going to then be the way to have that long-term sustainable change for those with eating disorders than just feel like I had an eating disorder and now I swapped it out with, something that's not adaptive, but isn't as harmful as the eating disorder. There may be some cases where there does have to be a gradual scaffolding where you can't just pull out the coping mechanism and ask people to tolerate. So there may be some times in some cases where that is the case, but ultimately our goal is to, work towards emotion regulation without having to rely on anything external to regulate.
Thank you again for that answer. I'm going to read off a question that I think may have been answered in the chat already, but I just want to make sure that we speak it aloud for the recording. Christine, who works in a high school, asked, do you know of a good eating disorder or screener or questionnaire? Some questions that can be asked to get a better idea of whether eating patterns are problematic. And Nancy responded in the chat that Renfrew has a few screening tools that are available on the website, which is www.renfrewcenter.com. And she also provided her email address in the chat, and you can follow up with Nancy directly at ngraham@renfrewcenter.com. Hopefully that answers your question, Christine. If not, feel free to raise your hand or drop another question in the chat. And then Sarah is just wondering if Renfrew is using DBT then for treatment of eating disorders or some other variation of skills training.
Yeah, absolutely. So what we use is called the Renfrew Unified Treatment Model. So what that is an adaptation of the Unified Protocol, which was founded by David Barlow, and the Unified Protocol is specifically for anxiety and depression and is evidence-based to address both of those diagnoses. So what it is a transdiagnostic way of addressing the eating disorder. So we've taken the Unified Protocol, we've brought what we've learned as being a treatment center for as many years as we have been, and we've brought them together where we're bringing in principles of ACT, DBT, CBT, all of those pieces, in addition to a relational foundation, which is really what Renfrew is known for. And so the unified protocol has been adapted through Renfrew to treat eating disorders. And so that's really the model that we function from. So what I was describing with that emotion tolerance, the emotion regulation, that's straight from our treatment model that we utilize in all levels of care. And we do have an outpatient manual for that. And it's proves to be quite helpful in outpatient in addition to higher levels of care. But it's this main idea of taking some of the principles that work so well, that are evidence-based, that we know are great from CBT, DBT, and ACT, and unifies those together. So instead of saying you come to us to deal with the eating disorder, and then you go here to deal with the substance use, and you go there to deal with trauma, we're able to address the core underlying mechanism that influences all of those presenting issues. Because as you can imagine, no one person is just struggling with an eating disorder, is just presenting with that issue. There's typically something else happening in that picture as well. And it's better to feel like you can go to one professional, one treatment center to address all of those issues by going to the core, versus feeling like you have to do a lot of like treatment hopping and playing kind of whack-a-mole as a practitioner, feeling like, oh, here's the substances, oh, here's the eating disorder, oh, here's the trauma. You can really get to the core of the issue and address that head on.
And as Ashley said, there's some information about that on our website too. There is the manuals she was speaking of are published through the Oxford Press, the treatments that work. It is an evidence-based treatment, and so you can get those manuals. Again, you can email me if you want more information about that. I'm happy to help you with that. Also on Ashley's one of the slide before people have to leave, I know we're getting close to the end. Renfrew does have tons of training. You can check again on the website. It's a wealth of information, the webinars, the free webinars, the CE events, the trainings. We are really committed to training professionals because we know there's not a lot of eating disorder training out there. So we're happy to try to help and educate as much as we can throughout the country. We have all different things available. So please feel free to access any of those. And if you do have questions, let me know.
Thank you so much. We have about 5 minutes left before we address the last question. I think we'll have time for one more question. I just want to confirm for folks, as noted, we did record this presentation. So we will be sending a link to the recording out to everybody that registered for this program. And also, Ashley, will you be able to share your slides so that I can send those out to folks as well?
Yes, absolutely.
Okay, fantastic. So we will follow up and get that information out to you probably within the next 24 hours or so. And then just to close, our last question, Jenny is asking if acceptance and commitment therapy would be appropriate for use in treating eating disorders.
Yes, I mean, I've gone to a lot of really great trainings and presentations done by, some really wonderful professionals in the eating disorder field that use ACT as a model for being able to treat eating disorders. I'm a little prone to the unified treatment model, and not just because I've worked for Renfrew for close to a decade, but also because I actually feel like it's very helpful in the sense that having the ability to pull from a variety of different treatment approaches, but that all are kind of unified, seem to work well. But yes, I mean, I've gone to many presentations by renowned eating disorder therapists that used ACT and find it to be really helpful and effective. So yes.
Excellent. Well, Ashley, Nancy, thank you both so much for being here with us today and to helping us provide this important information in recognition of Eating Disorders Awareness Week. Really informative. Any closing thoughts before we sign out?
Oh, just thank you to everyone for taking the time. And I so appreciate your willingness to kind of expand your minds and conceptualizations around eating disorders so that we can really tackle this illness and hopefully be able to, make a bigger dent in who's treated and access and informed care. So just thank you for your dedication to that.
Thanks
Right.
again,
I
Ashley.
I agree, Ashley. And also just anyone who'd like to come visit us in Paramus, if you're in the area, let me know. We'd love to have you come by and see our office and have a tour. Love to meet you in person. So thank you so much for coming today.
Thanks, everyone. Just a reminder, we have another community conversation scheduled tomorrow. It's rescheduled from earlier this month that had to be canceled. We have a presentation with one of the leaders of the Black Lives Matter movement here in New Jersey, and she will be here tomorrow with us at noon to discuss what's going on in the Black Lives Matter movement in New Jersey and how people can get involved in fighting for social justice. So maybe we'll see some of you there. You can register on the NASW New Jersey website, NASW-NJ.org. Thanks so much, everyone, and we'll see you at our next community conversation. Bye-bye.
Bye.